Big charger, just 2 and 3. Going right there.
No, two. Two's available. Yeah. They want VA, that's copy, that's right.
They're washing trucks and stuff. What time we start?
Get the RPR logo on.
Alright, we have 2 people watching. So we're going to get going. So we're going over documentation today.
Okay.
I went try. She's gonna go.
Victoria should be pulling up about any time too.
Are we just gonna meet here today or that train?
I don't need. So.
Don't you? So for those watching on YouTube, you have a nice little chat feature. You can utilize that. If you have any questions, and Nick's gonna be helping me watch out over my shoulder while we do this. Keep in mind that whatever you do say on there, this is our work, our agency YouTube channel, so please be respectful and do not do anything dumb.
It's supposed to be.
Yeah, or talk about the run, in which we are discussing in detail.
Awesome. How would I get inserts?
Any other, who's down?
Air spraying off the trucks.
He expired,
Sorry, December 31st.
pretty soon.
I only have 2 hours for it to use it for. Or 2, 4.
So this should be the only 6 hour already this year.
It's 12. Yeah, he's a spraying off the truck. You know, I don't like it's like. That's, I like it. Oh, you.
Nobody else is coming.
Lucas.
Case you get like half your truck washed.
Your call has been.
If she's not logged in on YouTube, so if she has comments. YouTube account?
Make sure if you're watching on the YouTube link, at least type your name in the chat, that way I know you're here. Put you down on the sheet. I got Trevor so far, I know Allie messaged Scott, so the other three, I'll put your name up. Just want to go ahead and get going. Sweet. I heard the door closed.
She's a mom.
There it is. Alright, real quick disclaimer, I don't know if you've seen the Discord, it is being uploaded and live to our YouTube channel, so please do not discuss any PHI, or be obscene gestures or comments. Be respectful, that way we don't have to start this over again. So, this audit review is over documentation. The reason this one came up is Nick, when he was starting going over the paramedic class and their documentation, he asked for a few runs, to kind of compare, to show them how to properly document. With that being said, some of the ones I got him, we had discovered were very poorly written, just for the acuity of themselves and how short they were and a lot of details that were missed. So that is kind of what sparked this latest audit review. He's back here, obviously. He's going to go into detail as well as what he expects from you all. He's already put out a nice friendly reminder on the SOP and what to document. But this is key stuff that he put out that we need to make sure we're putting in our documentation to prevent us from, legality purposes and making sure we're covering our butt for and foremost. Okay, so we're going to get going. I think there's like 5 that I have found. That, due to the acuity of it, seem to be very short and some great detail that's missing. So this first one we're gonna go over, is a 67-year-old male, 90 kilograms. Nick was on the scene, in county, so it came out of an unknown problem, person down. We took it by ground, it looks like, to U of L, here in town, in Stockbridge. So Nick, Kaylin, Austin, and Edith. And route time on team time was good. Depart, they were there for 30 minutes or so. Primary symptom is hypotension with other general local multiple. Here's the narrative. So dispatch to unresponsive male patient. Medic 2 marked en route, immediate response to the station without delay. Command 1 marked en route as well. Command 1 arrived on scene first and found the patient unresponsive in the bathroom with coffee ground emphasis on the majority of the body. Upon arrival on scene, 9101 advised we will be intubating to get the stretcher and the reeve sleeve to the door and set up for our side. Paramedic Paul got the reeve sleeve to the door with the assistance of the first responder. Paramedic Smith set up RSI. Gathered the following: 7.5 ET tube, 8G, cuff filled syringe, Thomas tube holder, baby bougie. Patient was brought to the ambulance where he was loaded and secured for transport via power load system. Patient's vitals obtained and found to be noted. Blood glucose 550. Via finger stick bilateral 20s were started by paramedics Oleg and Stickles. Both attempts were successful using clean aseptic technique, one in each AC. Blood was obtained for EC8 plus ISTAT, that LR infusion initiated in left IV site with pressure bag. Patient ventilated BVM with 15 liters per minute of oxygen. Patient given 100 milligrams of ketamine via IV and flush with saline. Approximately 2 minutes later, patient given 50 rocuronium via IV and flush with saline. Approximately 2 minutes later, paramedic while attempted intubation. Upon confirmation of ET tube, it was determined that intubation to the attempt was unsuccessful. Paramedic then removed the ET tube and intubated with success. ET tube placed at 23 centimeters of teeth, inflated and secured. Intubated verified with auscultation, condensation of the tube, and waveform capnography. ISTAT resulted and found as attached. Patient was placed on the ventilator settings as follows. Height set at 74 inches, peak pressure 15, peak of 5, FiO2 80, rate of 12. Patient was started on dopamine at a rate of 5 mics per kilogram per minute via IV pump. After approximately 10 minutes, there was no notable increase in BP. So the dopamine was increased to 7 mics per kilogram per minute. Patient was given 100 milligrams of ketamine for post-intubation sedation. BP rose to the 150 systolic. Dopamine was decreased to 5 mics. BP remained in the 140s. Dopamine was stopped and BP remained stable. Upon arrival to destination, patient was taken inside room 9. Patient was kept in room 9. Patient was sheet drawn. Patient care was transferred and report given all time approximate. So, what you guys think?
Why did we intubate him?
Yeah, I'd like to know why.
There's a lot of detail from the time that Nick got on scene to we're going straight to innovation. Like there's no, other than the coffee ground, and this is not very detailed information of how they were presenting, why he did what.
I mean, it's,
I was not there, so Nick and Austin was, and Kaylin. So if they want to
There's a
talk
reason
about
for
that
it.
in detail.
There's a reason for it that I'm gonna go into right now. So
Okay.
it's the run, could have been documented different, but due to some occurrences, there's documented to the best of the ability.
Okay. But yeah, there was a lot of information that could have been documented, like he said. So we want to make sure that we're documenting everything that we're finding, and also documenting why we are doing what we're doing. We can justify it.
I will tell you, the patient's GCS was 3, ataxic breathing when I got there, completely comatose, unknown downtime. Had been for a significant amount of time. The grade of emesis that was on his body was very dry on the walls, on the floor of the home. So, initial vitals were dog water, pupils were sluggish,
Yeah.
a lot of things.
Initial BP was
All of that should have been documented.
64/50s.
I'll say it also said primary impression was hypoglycemia, but it also said blood glucose was 550. Also no description of the patient.
there ain't notable finding.
Instead of
Yes, I believe it was as an attachment. I usually just scan it as attachment
Yeah,
instead of
that's-
typing it. Is it preferred to type it in?
Yeah, but you can see how.
But like with anything that happened, so like if their pH came back at 7, you would justify like just breathing rate.
But attached, that was noted in an attachment, but I will change that in the future.
See like a patient height and weight.
That's what I was gonna say. If we're
Is off of our event setting based on
The patient height did.
yeah, that says 74 inches, but yeah, I would agree. I'd like to see if weight base. Let's put that in there. That way we can.
I think I put weight in demographics, which obviously we won't be able to see on the PHI side, but I will also start putting that in there just for things like this.
Yeah, it said 90 kilograms, and that was at the very top. But we all know, we're taught very early on in our career that everything matters. But this right here, this section is what will hold it, okay? So, like he said, there was a lot, and I agree, I kind of know the backstory of this as well. So, there was a lot that,
Yes.
was documented the best that they could have been. So, it's all good, but yeah. So anything we're gonna do weight-based for the paramedics, especially the newer ones and the ones that are coming up, make sure we're documenting, if we're gonna give something weight-based, we put their weight, and this is the dosage, and this is what we gave.
Initial blood pressure was.
Wait, 6'2", and you got
Initial blood pressure was 64 by 37.
So,
I think with an 8, let's be that tall.
He was probably, but he was very small. He was very lanky.
IV, innovation.
I'm under the impression. Working with as much people.
Go to GCSs. Alright. Any questions on that? Next one, 56-year-old male, proven by himself. It's like a home residence, to Clark. Trevor and Corey was on this one. Alright, this one suck, but anyway. Scott County EMS emergency response lights sirens to South 3rd Street for a male complaining of difficulty breathing. Upon arrival, EMS was greeted by patient's family. Family advised that he is the patient's brother, and his brother is altered and having trouble breathing. Patient was found sitting in bed. Patient was alert warning ×2, CMS ×4, skin warm, pink dry, eyes pearl, negative JDE, trachea was midline. Patient was complaining of difficulty breathing. Patient was visibly struggling to take a deep breath, using the sensory muscles to breathe. Patient was found on home oxygen at 2 liters per minute. Patient had visible edema in lower extremities and hands. Patient was assisted to the stair chair and secured. Patient was removed from the home via stair chair due to limited space at home. Patient was assisted from stair chair to stretcher via stand and pivot. Patient was continued on home oxygen therapy. Patient was loaded into the ambulance without incident via stretcher. Patient vitals were obtained and recorded. Patient placed on end-tidal cannula at 5 liters per minute. End-tidal was low with long waveform. Vascular access was obtained successfully using 20-gauge angiocatheter aseptic technique. And patients left AC. 3 cc syringe was used to pull blood for an ECA. Patient breast cells were bilaterally diminished and notable rails. Patient was placed on a dual neb treatment for respiratory distress at 15 liters per minute. Patient was confused and showing signs of depressed respiratory effort. Patient was still using accessory muscles while breathing, and respirations were fast. The CA results were obtained. The patient's labs indicated respiratory acidosis. A secondary line was obtained using a 20 gauge angio and clean aseptic technique in patient's right AC. Access showed no signs of infiltration upon flushing and was secured with the commercial device. Patient was altered to baseline and respiratory effort was decreasing. Patient was prepared for intubation. Patient was estimated to be 52 kilograms. 50 milligrams of ketamine was drawn in a 3 cc syringe. 50 milligrams of rock was drawn into a 5 cc syringe. Patient was administered ketamine, and approximately 1 minute later, patient had not became unresponsive. Patient was given an additional 25 of ketamine. Patient was now unconscious. Ketamine was administered. Patient was confirmed to be unconscious and unresponsive. Patient was assisted with ventilation until SpO2 of 88 was achieved. A one scope 3D blade was prepared, and a 7.5 ET tube was ready. Patient was confirmed to not have a gag reflex. One scope blade was inserted in the airway and vocal cords were visualized. Bougie passed through. The vocal cords without incident, and tube was slid on Bougie into the trachea without incident. ET cuff was inflated, and mechanical ventilations were continued. ET tube was confirmed with one scope recording, bilateral breath sounds, condensation in tube, end-tidal CO2 reading. Patient became hypotensive post-intubation. Patient had a palpable carotid pulse. The megatrope was contacted, and ER physician Dr. Carter suggested Levophed for hypotension. Paramedic Combs confirmed doctor's suggestion, and Levophed drip prepared. Medic 3 requested Medic 2's assistance on scene and marked it. Patient was placed on Levophed drip at 0.5 mics per kg per minute via IV pump. Due to low end-tidal reading, tube placement was checked with one scope, and an additional picture was obtained and confirmed placement. Medic 2 arrived on scene. Paramedic Austin Smith began to prepare ventilator for patient. Patient was placed on ventilator at a rate of 12, PIP 15, PEEP of 5, and an FiO2 of 50% at initial settings. Patient was transported emergent to Clark Memorial. Patient had a notable rise in BP throughout transport. Patient's Levophed drip was decreased from 0.5 to 0.3. Patient was administered 25 milligrams of ketamine for post-intubation sedation. Post-intubation sedation twice and attempting to breathe over ET tube. Patient was also administered 2 milligrams of Versed. Patient's vid standings were adjusted to a rate of 10, PIP 10, PEEP of 5, and FiO2 of 100% with an IE change of 1 to 1.25. Patient had no notable change in route to receiving facility. Patient unloaded at Clark Memorial Hospital without incident via stretcher. Patient was registered and taken into code room. Per triage staff direction, patient was transferred from stretcher to bed via draw sheet. Patient was disconnected from SDMS equipment. Patient left in bed with bedrolls and staff at bedside. Paperwork was signed by ER Brittany Bullock. Due to patient being sedated, intubated report was given. Patient report was attempted to be given to our physician, Dr. McKnight. Dr. McKnight was unreceptive to EMS report and chose to ignore EMS. Detailed report was given to nurse in the report. All right, what do we think?
Do we see the lab values?
Oh, sure.
Go to the levels.
Items? We started off pretty strong at 122, 111, 120, and then 463. I'm assuming this is where the limit is.
I think this would be a good case for the whole resuscitate before you intubate thing. I noticed they said they only got a SAT of 88. I understand you can't always get above 94, but that's ideal. And were they tacking? Yeah, they were attacking one of those pulses with 126, so they might have needed a little fluid bump or switch dose before you intubate.
Was all this done prior to you getting there, Austin?
Most of it, yeah, he was on Levophed when I got. He was already intubated. I got the it ready and then probably after we got in.
Okay. So as far as narrative and documentation,
Descriptive, like,
very descriptive. He was very detailed, to the point where you could actually almost be picturing this in your mind as we're reading it. So he had a very good, thorough description of what was going on.
Vent settings are wrong.
Do you want to elaborate a little? Well, I don't know. PHI stuff, I don't know.
IVR was needed here.
with a patient that's already hypoxic, it's part of the 100%, instead of 50.
And IVR was definitely needed here.
I don't like that the mode that was used was put in there.
Mode?
Assume it was PCMB, but it doesn't say that.
Yeah.
I think based off the vent settings, you could probably tell. I don't think that you need the mode so much with settings that we use, but I venture to say 90% of the people don't put the mode that was used in there. But I would definitely say that IVR was definitely needed on this patient based off of the vitals and the entitled. What's your question over there, since you both were confused?
I didn't know what IVR was.
Inverse vent ratio. So typically you have like a 1-to-2 or a 1-to-3 or a 1-to-4 IE time. It needed to be inverse where there was a longer inspiratory time. Sure. You'd have like a 2-to-1 or a 3-to-1. You do the inverse ratio.
Is it related to that IE chain?
So if I was on the phone with Trevor for a majority of this run, get him to correct the initial settings and with, at the time, his lack of deep understanding of the vents was, that was the best he was able to achieve.
Probably, does that one scope save on here, or do I have to go and look at it?
Anybody on YouTubes or Ellie have anything?
My protocol question, I noticed in left vent dose, he put in a weight-based dose. I thought ours was just a straight 8 to 12 mics per minute.
It says, Carter.
These are protocols. Not that his dose was that far out back. Specified not a weight-based.
Dopamine is weight-based for level is a straight volume for dose over time.
He math is out of control.
What do you got going on the screen?
It's hard.
Look above you.
Oh, to
Look
me.
above you.
Oh,
Did we click something?
I was trying to see if that, the video of the innovation. I didn't, because I hit something, I was like, where's it at?
Oh, Trevor, I see your comment. Pump only does a weight base. If you put in basic infusion, you can put in whatever you want.
Yeah, I don't think that's it. Trying to pull that up, that video. Could this be a good time?
You pull it up, I just. won't touch it. With. Media player.
Save it.
Trevor said the video was 5 minutes long, couldn't shorten it, so it may not have taken.
Okay.
I remember, I think.
It's not taken. We'll try on a different one. So is that? So was it a 5 minute innovation or is it just like maybe 5 minutes of time to turn it on? And it just uploads everything?
Yeah, you can
can't play it, okay.
continuous video.
Here doing that, ketamine, rock, be saying no draw, ketamine.
Ketamine was pulled with considering the patient's vitals, but that's just my preference.
Already being hypotensive. And that could have been, so when we started off here and dropped, that could have been a result of those two doses
Yeah,
as well.
accommodates a much safer drug to use in this instance.
Is that why he went?
I think he probably went light on this ketamine because at least he recognized that this patient was already altered and not alert, so you can have no screening now, so you know what it does to prevent any huge hemodynamic shifts.
And he very well could have been very sensitive. Any other questions, additions, deletions?
Anybody else added to the current, Austin just responded.
Just showing those two still. So yeah, so make sure, no matter if it's Kaylin, Nick, whoever, somebody that responds with us, you know, if they're involved in patient care, they need to be listed on there as a, yeah, especially if they're doing things.
How's his signature on this?
I don't know if it puts it on this one.
Oh, yeah, there's no PHI on this.
Yeah. There's a chance that there's not there.
Oh, you get me.
Alright,
I do think the documentation.
yeah, very, very, very descriptive. Alright. Next. He is 78-year-old male, 124 kilograms, making myself, we're there. LBC, looks like on Finley Firehouse, Scott, Nick, Gage, Carletta, Nick, and myself. Yes, this was a cluster. It was a 2-car MVA. This was the driver. So medic 3 responded emergent, immediate response, once cleared from a 15 call upon arrival at the scene. Patient was noted on the ground, supine, pulse, fully dressed, blood noted in left ear, pupils equal round and sluggishly reactive to light. No other obvious injuries noted. The patient was reported to have been compressed in the driver's seat, a fully inverted vehicle, pushed into a field off the roadway. After being struck by another vehicle, knees to face, unrestrained, significant intrusion into the seat. Emergency move from vehicle when he was noted to be abdominal breathing. CPR initiated. Patient was found to be in PDA. Major S. Williams attended 20 gauge and right forearm. Clean technique. Flash noted. Flush with signs of infiltration. IV removed. Chief Oleg initiated 20 gauge. IV left AC. Clean technique, flash noted, flushed without signs of infiltration. Secured, administered epi 1 to 10. Intubated, direct with a 7.5 ED tube, esophageal due to movement. Esophageal due to movement complication on first attempt, immediately corrected, ET2 7.5, no to passing the cords, depth at 25 at the teeth, cuff inflated, secured, condensation noted in the tube, ventilated without difficulty, confirmed with direct digital waveform capnography, patient Lucas. 3, a mechanical compressions initiate. Patient noted to have Brady pulse. Patient then impulseless VTAC at next check, defibrillated, administered 300 milligrams of amio. Patient placed on backboard, secured ×3, carried to lower stretcher, secured ×5. Rails up, care taken to minimize ongoing resuscitation efforts per AHA guidelines. Patient loaded into ambulance. Continued resuscitation efforts. Patient noted to be in VTAC with a pulse. Defibrillated again. Patient noted to be pale. No bleeding aside from ear. Halo test attempted on ear blood, but minimal blood came out. Hearing aid noted to be in place. Unsuccessful halo test. Patient returned to bradycardic, PEA, and back while en route to Scott Memorial Helipad. Patient diverted to ER due to concerns for stability. Continued ventilating patient with BVM via ET tube. Eyes noted to be pearl. No obvious external injuries, deformities, or contusions. JVD midline had to have been soft. Upon arrival to Scott ER, patient unloaded from ambulance taken to room 4. Report given Dr. Hicks. RTs and nurses present at bedside. Patient transferred from lower stretcher to hospital bed via sheet pull by crew and staff with Lucas in place. Continued resuscitation efforts by ER. Patient was transferred to Norton Clark, all times approximate in a report. What do you think?
Where did they take this patient?
Scott.
We took him to Scott.
Okay.
Wasn't Sonoran Clark,
Adam.
And it was transferred to.
patient care.
So, minute thing there, but we need to make sure we're thorough in our documents. Because how many times we get people, where'd you take them to? Now we look at run reports, you say Scott, Clark, when actually we took them to.
One thing I noticed, it said,
Yes, Trevor, but it's missing that keyword in there called Scott.
One thing I noticed was that it says tube depth 25 what?
Okay.
We know that it should be centimeters, but should we not put that in there?
I get what you're,
I just always try to put a unit measurement with everything.
we're dropping the, OG and NG, that would make sense because that would make sense there.
And then there's one, the second to last line of the first paragraph says patient noted to have Brady pulse. And then it just says patient then impulses VTAC at next. Did we continue CPR after
Yeah.
the Brady pulse?
I wrote in with
But
yeah.
looking at this, you'd have to question that.
And also talk about Brady, PEA, and then back. And back while I'm around. That seems a little confusing for me.
How many doses did that baby was given?
I think what I gave.
You mean, should we?
There's only one listed in the manual.
Also, how did the patient get out of it? It says,
Yeah, so we had
who removed it? Was it you guys? Was it the
Fire.
fire?
they used the glass master and cut the windshield out and
So he had to be
scorpion in, and then once we removed it, we could assess initially. And once we removed it, Nick and I went them out all the way back to the truck to get it.
It just
So we had to take a jump on it.
says that they found him on the ground. It explains how he was in the vehicle, but it doesn't explain how he went.
Yeah, well, she's just documenting, what she seen once she had gotten
Well, it says emergency moved from vehicle. He was noted to be there.
Yeah, but that could just mean like pulling him out, but it.
No, I get it.
Like, cut out of the car, did they have to like fully extricate, was he?
Yeah, it was still on its side. I just removed the windshield and so Derek was there as well.
Yeah, I don't think Carlotta had arrived on scene yet, because she was on another run, and, there were multiple patients. Me and Ryan had got there first. And then,
Would,
took a different patient.
would that merit a second portion of this narrative be written by somebody else?
As far as
When they got there, what happened?
well, we couldn't do anything. Cause actually, it wasn't you like trying to see what you had in your car to try to get the windshield out while we were waiting on fire. Cause we very limited, cause unstable car on its side, the edge of the cornfield, muddy ditch, all the factors were there. As far as nothing we really.
We don't know that from this.
Yeah, just put 3, subject when I was Clay 16, 19, was for Clay Avenue, dialysis, 7-year-old female, that's for 3.
But, like somebody said over here, 3 EPIs were given, but only 1 was documented. We need to document every time that we give a medication. And I want to say we need to also, I'm sure you would probably agree, Nick, document like how much we're shocking for defibrillating, what joules we're using. Yes, no, different.
And the monitor does it itself. I think it's important to be altered. Definitely be.
From the original setting. Manufacturer. Okay, fair enough.
She's doing on her own, right?
Do a,
I was confirming that these, the jewels on their own.
yeah, and it also tells you like on your printout too, like what it shows.
Yeah.
What meds were given?
Epi, and amio.
This dude is the one that we ended up with a chest tube on, a couple of pairs.
Yeah, he was a trainer. Yeah, that was, everybody got to play in the ER.
No, we
In
needed,
the first chest tube that we did, and I,
He ended up getting transferred to UL.
and then they called him as soon as
But yeah, they took him to surgery and they got in there. Like, really, they started like,
yeah, they were all back here a while.
Yeah.
Farland and
Blonde girl, wasn't it, that they were named?
Casey Hill.
Casey.
Yeah.
The loud one?
Shit,
The reason I was asking about meds,
She was there.
I think, yes, we should follow AHA guidelines, but we need to think about H's. I know we don't have blood, we try volume because they're in PEA, probably from hypovolemia.
We did have fluid,
Well, it doesn't say that.
Right, and she messaged, I think, if she was pertaining to this report, she said she mucked it up pretty good. So, I know we were busy that day, but that still doesn't warrant a poorly written narrative.
The epi wouldn't be nearly as important because it's a fluid problem, it's not a constriction problem.
Yeah, because we got so, when Nick did that chest tube, like, I was there helping, keep everything flat, and once he punctured with that tube, the blood just came out everywhere. So, yeah, I would agree more of a volume problem than it would
With
be.
that in consideration, would you consider ringers or plasma pipe?
Plasma pipe would be better.
I speak up, or when I can't hear.
One thing I'd like to see is how
Speak up a little bit, because she's trying to hear what we're saying.
he was moved from scene to the ambulance, like, that's a significant MOA, there's nothing about, any ceasefire precautions. How he was moved, was it backward, was it reef sleeve, like,
Backboard.
that's my bad, I didn't see that.
And C color, but it's, once again, it's not on there.
Gotcha.
It's easy for me to sit here and be like, yeah, that was done, that was done. However, like for you all that was not there, it's gonna be hard for you to decipher. Because like I said, Nick and I were there, there was, sorry, Cammy, but you forgot a lot. There's a lot that was not put in here, so. Yeah,
I wouldn't question anybody's care, I'm just saying, like,
but it's also small details.
if it's not in there, how, you know, heck,
And like I said earlier, we're taught early on, even whenever people were teaching my EMR class in 2000. Documentation is key and making sure that if it didn't get wrote down, it didn't happen. So we
Because
need
like, this came back that like his neck was snapped and then, there's no C collar on there, it happened from the record. It happened.
poor care.
Right.
100%, yes, I get it. So we need to make sure we're taking that extra time to document thoroughly and appropriately. And like I said, this isn't a bash on the ones that we have pulled up. This is just us getting to point A to point B to all become better providers, and making sure we're doing things. Nick wants them, our building wants them, and we're keeping everybody happy. All right. Any other questions?
She said it may be a procedure for the collar.
No. I was kind of confused also, and you guys may have know what she's talking about. But she's talking about esophageal due to movement complication on first attempt.
Used it. Guess maybe.
Okay. Oh, okay. All right. I don't know. Like I was just kind of confused when I was reading it yesterday. So, but it makes it plausible. I'm saying that is true. It's possible.
I was with my own patient when she was intubated.
Yeah, you.
I remember looking over my shoulder and watching, seeing that she
Yeah,
was.
we innovated out the field.
Yeah.
Back there in the corner. Because yeah, you have the other
I had the
part, the other part.
signal already.
We did have a brief, talking brief, loss. Yeah. All right. So, do we have anything else other than? Okay. Go. Okay.
Anyway, you got Tyler.
I got one more, and I don't. And this one is going to be more. Actually, we might already. Uh, I didn't see any issues with this, but I was just talking about how detailed. So, 59-year-old male in town. And Kaylin and Nick. Public building, assuming that's per world. So Clark, so Dylan, Scott, Nick, came out as unresponsive, depression, foreign body, and esophageal pediatric. We went whistle on this. That's a good idea. You want to read your narrative, Scott? Oh, never mind. So, Scott County EMS dispatch code 3 to Cracker Barrel for a male down in the bathroom. Responsive. Dispatch further advised CPR instructions are being given to bystander, medic 1, ALS 3, 191. Responded immediate license siren with no delays. Med 1 arrived on scene with 91 about 91 advised the patient has a pulse and is vaginal breathing. EMS proceeds inside restaurant and bathroom where a 59-year-old male is located, being tended to by 9101, 9103, and FD responders. Patient lying supine in the front of the sink and pants are noted to be wet. Fire department administered 4 milligrams of Narcan, 9103, obtained IV access and left AC with, then administers 2 milligram IV Narcan. Patient skin observed warm, pale. Breathing is approximately 6 times a minute. Strong, regular pulse noted at 80. Patient vitals obtained with SpO2 noted 79%. Room air, BVM BVM ventilation began at 12 to 20. Patient had no response to Narcan. Upon further investigation, pants were wet from vomit. Oropharynx is noted to be cleared. Lung sounds auscultated with diminished sounds throughout. Caretaker on scene advised the patient has developmental issues, takes limited meds, and is known to eat too fast. Decision made to move the patient ambulance at this time. Patient placed in reef sleeve and then lifted to a waiting stretcher. BVM connected at O2 at 15. Patient secured to stretcher and then moved to ambulance without incident. While moving patient, he is noted to flex arms to stimulants. Full set of vitals obtained. Patient is sinus rhythm, SpO2 improvement in 90s with BVM. Pupils are observed approximately 3 millimeters, non-reactive to light. Helicopter is requested. Decision is made to perform RSI due to the possibility of aspirating food and not protecting airway. Patient is estimated approximately 70 inches and 80 kilograms. 9103 obtains additional 20 gauge IV access in right forearm. Blood glucose measured at 250 via venous blood from IV stick. After pre-oxygenation, pre-oxygenation via BVM, patient is at 99%. SpO2 equipment is prepared and double checked. Patient is administered 20 milligrams of etomidate, slow IV push, approximately 2 minutes. 50 milligrams of rock given slow IV push. Patient observed flaccid with no response to eyelash flick. Intubations began with video laryngoscope MAC 4. Difficulty encountered due to large piece of food covering vocal cords. Suction performed with Decanto. 7.5 millimeter ET2 was then advanced to the vocal cords with aid of a bougie. Depth at 23 centimeters at the teeth. Cup inflated to 30 centimeters of water. BVM inflated, resumed with high airway resistance. Noted. Absence of CO2 waveform. No chest rise and fall. Bougie is reinserted through the ET tube to dislodge possible foreign object with no success. 16th French deep suction performed with bloody sputum observed and a hard stop before reaching depth. ET tube cuff deflated and tube inserted to a maximum depth. Tube then backs out to 20 centimeters at the teeth, and then cuff reinflated to 30 centimeters of water. H2O. BVM ventilation resumed with better compliance noted. Chest rise and fall. CO2 waveform present. Patient desatted to 80s during tube placement, but rebounds to mid-90s. 12 bleed performed. Showing sinus rhythm approximately 90. No FTP. Noted, Shark fin waveform noted, but to CO2 waveform with slight hypercapnia noted. 2 milligrams mag mix and 100 normal saline. Then administered over approximately 10 minutes to reduce bronchospasm. 100 milligrams of ketamine is administered for repeat sedation. Hamilton vent circuit tested and placed on PSIMV plus for following settings. Peak of 5, peak inspiratory pressure of 15, FO2 60. Respiration rate of 12. Ventilation began with Hamilton with low tidal volume, breaths observed. Settings were adjusted. The peak inspiratory pressure of 25, peak of 10. Which improves tidal volume to approximately 250 ml per breath. Respiration is then increased to 20 and achieved adequate ventilation. Lung sound auscultated with clear lung sounds noted in left lobe, diminished sounds noted in right. Caretaker informed of transport to destination to Clark due to them having ICU capabilities. Helicopter declines due to weather. Medics 1 begins emergent ALS transport to hospital at this time. During transport, patient is monitored continuously. Remains compliant to the vent, repeat sedation, analgesia, CO2 decrease to within normal limits. SpO2 remains mid-90s with bump of FiO2 at 80. Ketamine and fentanyl altered for sedation, pain control, eyelids taped closed to prevent accidental cornea abrasion. Lactate ringer bolus initiated approximately 500 mL an hour. Repeat of lung sounds revealed diminished sounds in right field. Report call to Clark ER. They await EMS arrival. Patient consistently delivered approximately 250 tidal volume breaths with minute volume near 5,100 ml a minute. Field impression and aspiration with food bolus possible lodged in right hemisphere bronchus. Patient GCS remains 3 throughout transport. Arrival at Clark, moved to facility stretcher, in bed exam 28 via draw sheet, patient remains on EMS monitoring equipment. Our report is given to staff once patient transferred to hospital equipment, patient is fully transferred. Patient will not be signed due to unconsciousness. No signs for transfer, for transfer of patient and patient rep, patient time, patient cares medical, clears hospital, and right back. Oh Lord. Good, bad, different what? stupidly detailed. A very good, very good written narrative. Down to taping the patient's eyes shut to avoid cornea.
He was gonna have them. So I tried to be as detailed as I could.
Do what?
I was afraid he was gonna have not good outcome.
Yeah, it seemed like he was presented with kind of multiple possible differentials at the beginning, and then quickly through a history and talking to caregivers, we determined that there was possibly your overall endo was a sort of food lodge in the airway. You had some, you did reach some sort of obstacles, pushed through those, and was able to get through those, and you battled through that. So you guys did a great job on it. Very descriptive with everything. I left this in there because just how great it was documented. You know, you had everything weight based, you had the patient weight, the weight height. I'm very impressed with this one. I was kind of in on a good one, on a high note. If anybody have anything else they want to add to this one? Yeah, I mean, everything is documented. Correct.
Just older, 50s.
Did you all have like a couple together that had food issues? Yeah.
So I'm just trying to figure out.
Alright, that's all I've got as far as the ones that we had found and I had looked through it. Yeah. You know, making sure that we're also documenting very thoroughly on SORs, because usually those are the ones that's gonna bite you in the butt. Making sure you're including, you know, the risk of them not going and making sure that, you're documenting vitals if they do want them, because you never know what's gonna happen. Can't force these people to go, but we can strongly encourage them. We have to be good advocates for patients. So, you know, if they're not gonna go and they're headstrong, we definitely want to be very thorough in our documentation on our SORs. You know, the feed lift assists and stuff that I had read are very detailed. So I was very happy with that, you know, that aspect of it. I didn't read all of them. There's an abundance. We are very busy. So for me to sit back and read all of them would be very, so I was trying to get the supervisors and other ones who do the QA, if something was kind of got their attention, to let me know. Unfortunately, nobody approached me with any, well, I guess fortunately, nobody approached me with any concerns or ones I need to bring to the table. It was kind of found needs by chance, so it was, you know, we determined that day that our next review would be documentation purpose. I don't have anything else, Nick.
You go back up to the-
Yeah. Like I use it kind of with battery and RAM, just kind of up it on there.
That's why I didn't remember. About this big swing here, but I told them we didn't have a choice. I didn't want this, that's all I did.
Yeah, because if that was, essentially that would just be only one line, instead of a complete line, it's not getting anything. Is that why he's only getting
He was
returned
still
two
having
fifty?
air, he was having the air.
Okay,
So if you're having some air movement, like right main front, and you have that big jump in inspiratory pressure on the vent, are you concerned with potentially overinflating left lung while you're trying to push through on that right? How does that work? When you jump your pressure up, you're having some air movement to the right lung that's obstructed.
We don't, respectfully, we don't know that this is the right basement. You could have punched a hole through some bullets in his main bronchus. We don't know. Having ear movement on both sides, diminished or not, it's showing that something's getting some. The only way to know that you're not is if you're having zero air movement inside. You've got the pressure, but you're only delivering that much. So there's air trauma happening at 250. Unlikely. If that, we had to do this to achieve that. You know, if this is 700, then we've got a different conversation. But
Do you wanna end on anything as far as,
there's a group of people that do a really good job documenting, and there's a group of people that document and get done. I'm not saying every report needs to be something similar to this, but there needs to be detail of everything that we're doing in the report, regardless of how minuscule that it is, because it could be important later on, or it could be important to billing, or it could be important to this. So, I'm glad to see that he's kind of followed in the realm of what I've asked to do as far as breaking this up into sections. Inside truck delivery. It's easy for us to find information when we're looking for it. Some people that just do one big paragraph, which is fine, but I feel like when we just do one big ass paragraph, we can get a lot of details. I think it can get done because we need to be conscientious. I'm paying you to do this, so if it takes you an extra 20 minutes, it takes you an extra 20 minutes to do it properly instead of go back to the way you were doing it. But because I think we can see there's a drastic difference between this run report here, which is pretty cut and dry. There's a shit ton of information. And then some of the run reports that had a shit ton done, not a lot of information. While this wasn't a difficult run, all the information plus some is there that we need. Some that are sketch, not that we're doing sketch shit, just that it's, there's a lot going on and a lot of presumptive calls being made by providers. I believe have a lot of necessary information. On Austin's front, why we're choosing to do things, we need to articulate why we're choosing to make a decision to innovate, or why we're choosing to give a medication. Due to this, due to suspicion of this, due to suspect of this is why I'm doing these things, needs to be articulated. Especially under higher acuity rooms. All of these are high acuity rooms. So that should be laid out in your narrative. Due to these reasons, I'm doing this.
you out there anything?
YouTubers or anything?
You out there YouTube Lane? You guys have anything else? I know you've been trying to put in Discord as well.
Even something that someone did, so.
That will conclude today then. If you were on the link, I have Allie, Trevor, Kenny, and Teresa. I have 6 people, but I'm missing 2. Just put your name in the training on Discord. That way I know you were in there and I can get you down on these. I don't. Oh,